I'm Nora Stern. I come from Providence. I do pain education development, and I'm going to talk with you about some new ideas about how to work with pain. But first, I'd like to ask you in the audience, how many people have had pain in the last 3 months? A good portion. And I'm guessing that of you, quite a few have had pain that's lasted for more than 3 months. And when you've had persistent pain, it can be a frustrating experience. It can be actually even be kind of scary. In this country, we're in the midst of really a pain care crisis. We have quadrupled our use of prescription pain medications, with opiate overdose deaths skyrocketing and pain care costs through the roof, without an improvement in pain care itself. And it's really got to do with how we think about pain. So meet Susan. Susan has had pain for 10 years. She's used anti-inflammatories and rest when it gets bad, and she goes to her doctor who does some imaging. She finds out she has spinal degeneration and has surgery done, injections, and she goes on pain medication. And her pain gets worse and worse as she gets more and more inactive. And her healthcare providers don't want to treat her anymore because they don't know how to help her. And this is a really common problem. So what are we doing wrong? Well, one thing we're probably doing wrong is actually how we think about pain. For many years, we've thought that pain was a direct result of bodily injury. That little boy falls off his bike, hurts his knee. Mom sees him, runs to him, he cries. And we think that the reason he has pain is entirely due, or largely due, to the injury at his knee. That the body tells the brain that there's pain. Now, parents in the room. How might his experience be different if his mom wasn't there and he had to get back on his bike and ride home? Pain changes in relation to context. What about phantom limb pain, where amputation actually removes that body part, but you have an experience of severe pain in the remembered limb? How can we explain that? There's got to be a different way to think about pain. So people who've had pain for a long time, think for a moment about a time when you were really absorbed in something, really taking your attention, and you realized that you didn't have pain during that time. Now, yes, you were distracted, but we think that there was probably something else going on, that there's another way to think about and explain the pain experiences that we just talked about. So the way that the new neuroscience explains this is that actually it's the brain that puts together all of the information from a lot of inputs, including danger information from the body, and decides how threatening that information is. And based on the threat value, assigns more pain or less pain based on the meaning. And in fact, you can have severe pain without any tissue input at all, like with phantom limb pain. Pain in relation to context. So, little boy falls off his bike, mom's not there. In the absence of that extra information that he's in danger, he might jump back on his bike and ride home, very bravely and proudly displaying blood dripping down his leg. Pain changes with meaning. And pain changes with understanding. So on the left, we see basically a pain neuromatrix on an fMRI, on an MRI that shows a person who's experiencing pain, who then goes through pain education, a class, and on the right, a quieting of that sensitization because the meaning has changed. So pain changes with understanding. The threat value decreases. So we're using these ideas at Providence to create some changes in how we work with pain care. We've trained all of our clinicians throughout rehab in the state in this new model, and we have more than 60 specialists in inpatient and outpatient rehab working with these ideas. And we've trained all of primary care, and we have new ways of avoiding unnecessary imagery and surgery that we're working with. And we're starting to see some really great results. Very importantly, we're training our patients. So we have patients able to access pain education material online, and in written material and in classes. So they're starting to understand pain differently. And we're starting to see differences in, for example, clinics that use our tools most robustly having a 2.3 times greater reduction in use of the emergency room among patients who go to those clinics than at the clinics that don't, which is really wonderful news. So let's meet Susan again. Now Susan might go to her doctor who might review an app for best practice, and her case manager might advise her to watch a video online and then go to our pain education class. And there she learns that she's sore, but she's safe. So she goes to rehab, ready to be coached back to activity. She works with mental health. Now she's got a team. She's not alone and isolated. This is a different journey. Pain care is everyone's job, and understanding pain decreases pain. Thank you.